Good afternoon, everyone. Hope you all are doing well and fine. I welcome you all on behalf of Governance Now at Digital Governance Virtual Summit 2021. So today we are having a discussion on a very crucial subject, transforming digital health during the pandemic and beyond. So we have seen the acceptance of technology and digital health during pandemic time like never before. So we are today we are having interesting deliberations on how digital health and national digital health can be resolved. So today for the fireside chat, we have Shri, Kiran Anandampillai, Advisor Technology, National Health Authority. And to moderate the session, I invite Shri Sridhar S, VP, Cloud and Security Services, Tata Communication Limited, and Shri Bhushan Choudhary, Director Government, VMware India. And I request Shri Kailashnath Adhikari, Managing Director, Governance Now, to welcome the August gathering and our esteemed speakers.
Thank you so much, Pragya. Good afternoon, ladies and gentlemen, and welcome to the Governance Now webinar on a very important topic under the entire pretext of digital governance. For this particular session, we'll be discussing about transforming digital health during the pandemic and beyond. We have all seen the unprecedented crisis that the pandemic has caused since the past year and a half, not only in our nation, but also globally. And it is quite an important time also to discuss how technology can actually help us during the pandemic and also as we progress towards vaccination and in the post-vaccinated world as well. So with this, for the first fireside chat, I welcome Shri Kiran ji, along with that Shri Sridhar ji and Shri Prashant ji. Over to you.
Thank you. Thank you very much, Mr. Adhikari. It's a great opportunity to be here. First of all, I hope everybody is safe and fine, and their families are also doing fine. It's a good thing that you've offered to spend your time with us for this afternoon. A warm welcome to Kiran once again. Good to see you again, Kiran.
Thanks, Heera.
So the good thing is in India, this Ayushman Bharat, this thought about digital health predates the pandemic. So something that we've got to be proud of, that the conceptualization of this happened much earlier. The interesting thing is this NDHM white paper, once somebody reads the blueprint, it's just amazing how visionary this document is and how it's going to encompass the lives of all the citizens of this country. So it's a great thing. So Kiran, starting from there, thinking of creating this kind of a medical identity, associating the records is an absolutely complex thing. And considering the scale of 1.3 billion people, obviously you won't get scared by it, having been a part of Aadhaar and having seen this from grounds up. Once you're going to do it encore this time for digital health. So with the NDHM that is being launched now, and it promises a medical identity, the Prime Minister spoke about it from the Red Fort. So helping achieve this kind of a digital infrastructure, how has technology helped create this kind of a momentous and stupendous platform? And how has closer home cloud helped you in achieving this goal? How did you just go about putting this together? Maybe you can start off with that, Kiran.
Sure. So I think, Sridhar, thanks so much. And as you rightly said, while the ideas for the National Digital Health Mission do predate the pandemic, it was actually launched in the pandemic year. Last year, August 2020 is when it officially kind of got kicked off. And so much of whatever work that we have done has actually happened through this pandemic period. The National Digital Health Mission has to some extent and also been called, the UPI of healthcare. So the idea is to kind of provide a set of digital building blocks with essentially APIs that can be used by the ecosystem to deliver the benefits that we talked about. Like, for example, how do we create a longitudinal health record and so on? So we can get into that. But coming to the cloud aspect of it, let's be very clear that nothing like the ideas that are there in the blueprint would have been possible without the emergence of the cloud. The whole architecture and the thinking is actually designed in a world where we kind of accept that connectivity, connected apps, and the fact that you can have a set of bunch of APIs and cloud-based services as a kind of an base normal. So, everything is built on the top of the idea that, hey, these are things that have been kind of provided for us in the past decade, and that they have reached a certain level of maturity where we can actually now build for the next decade on the top of these things. So pretty much every building block that we look at in the digital health, whether it's the issue of a health ID or whether it is the ability for us to move around personal health records in a way that is completely compliant with the personal data protection bill, is all built on a set of building blocks which only offer completely faceless, just APIs running on the cloud in the back. So that's the fundamental design and the basic of which even how we are architecting the whole system. So let's start with that, and then we can look at how some of those elements or any other queries that you have that can help you address this better.
Sure. Mr. Kiran, maybe taking a clue from Shida and what you said, I think a lot of work has gone in last 1 year after the pandemic hit, and obviously it is work in place right now. So my understanding is NDHM pilot has been successfully implemented.
It's still ongoing, Prashant.
Yeah,
so, we are not yet national. So we're still in the pilot phase. Yeah.
So 6 UTs, I feel initial phase was addressed. So what challenges do you foresee actually? So that's a point.
Sure. So I think, the UTs were a very interesting place because on both fronts, in terms of number of presence of health facilities also, they're not really very strong. They are probably more poorly served except for maybe Chandigarh and Pondicherry. Especially if you take Ladakh, Andamans, they have definitely far fewer healthcare facilities and features than the rest of the country. And two, they also have certain connectivity challenges. Internet connectivity to the Andamans just got better. They had a big cable coming in, but the rest of the places still have fairly patchy on connectivity. So both were very interesting problems from an NDHM perspective. So happy to share that, it has helped or shaped some of the building blocks in terms of how we design it, how we look at some of the elements around it. But to give you the construct of how this architecture works, what I would like to talk about is a couple of things, right? So if you take any health facility today, and I think we can assume today, given that computerization and digitization is in every field, you cannot imagine a sector where computerization hasn't happened. So one of the key assumptions we are making is that digitization of a health facility is going to be a natural course. Yes, you're going to find a clinic that's still probably using a pen and a paper, but with time, we think significantly you will see digitization. So we already see digitization in healthcare. Highest, if you will see it in, say, diagnostic reports. It will be quite rare for you to have not seen a printed diagnostic report recently, right? So subsequently, we think other things are also being digitized. Discharge summaries in a lot of hospitals are already digital. A few practitioners do issue prescriptions and OP consultation notes digitally, but that is still a much smaller subset compared to, the diagnostic reports and, say, discharge summaries. So we are basically looking to take these software on which these diagnostic reports got done. Usually they're called LMIS systems, or these discharge summaries were created, and make them NDHM compliant. So what does NDHM compliant mean? Essentially, we ask the vendors of the software to change their software in such a way so that they're able to issue these health records that they're creating on their software to the patients of that health facility in a digital way, so that it becomes added to the longitudinal record of that person. And B, also to make it in a standardized way format, so that it's interpretable by other systems and can be actually machine interpreted. So think of it as you probably got a COVID test done in the last year, and essentially you probably went to the website of some lab company and you probably put some code in and you were able to see a PDF. Now the problem is that COVID test report did not become part of your longitudinal record. The PDF format that I'm holding is not a machine readable format, right? So NDHM essentially changes those two. Apart from you will continue to do what you just did, but you will now be able to also make this part of your record, because that record with the lab gets linked against your health ID. And the format in which they're sharing that report becomes a standardized format. Now, what the power of that changes is, imagine that a few healthcare facilities start doing this. As many healthcare facilities come live, come online, start adding their records together. Your health ID holds the list of all the various health records and wherever they may be. And you, with your consent and control, you could use any app. So in the UPI world today, you make a payment using a Bhim app to a Paytm app to a Google Pay app, and you don't care anymore, right? You can go to any merchant and say, hey, you want money? I have this app. It doesn't matter what he's using on the other end. In an interoperable fashion, you're able to move money. NDHM essentially is going to help you do that for health records. So you will be able to go to any hospital, any other clinic, or even an insurer and say, okay, look, you want access to my health records here. You can take it from me. And you can use any app of your choice to control that experience. The other party can use any app of their choice to actually receive your records. And the records will be completely interpretable. And that's really what NDHM is actually creating. So I hope that helps you get a sense of this. Clearly, this is not going to be possible. We call this a federated architecture, right? So which means every software that's holding these health records has to be online. has to have a strong uptime, and has to be available and be compliant with the APIs. So this is really going to call for significant infrastructure in terms of cloud and cloud resources. On the top of this, we also need to make sure that security and privacy are taken care of, which means you don't want any of these individual entities themselves to be hackable. So the good part of this architecture is that there is no single central resource that somebody can hack. So it's completely federated. But the part is that you also have to protect each of these nodes. So both of those elements from a cloud and the technology perspective are going to be quite important as we kind of go forward.
Sure. And before I hand it over to Sridhar, so maybe I'll just have an extension to the similar question. And I think you gave a very view to how it's being done right now. And you spoke about that from a technology perspective, it has to be scalable, it has to be secure. So I think maybe a leading question can be, what technology has NHA thought of evolving this platform? So is there a specific technology you want to talk about? Or?
Yeah. So see, look, I think the approach, and this is something that we do typically within government, right? So you essentially want an ecosystem play here. So NDHM is about essentially ensuring that, so you can think of the building block itself. There is some way in which we have to build a building block, manage a building block. So there's a whole bunch of technology choices to how did we actually put together, say, some system within the NDHM. But more importantly, we want this to be usable by any entity who's participating in the ecosystem, irrespective of whatever software stack they have, right? So from that perspective, we essentially go completely with an open API and a standards-based approach, right? So for the external entities, all APIs and everything is absolutely standard specification based, so that they can decide whatever platform of their choice to implement it. The only thing that we do seek is that before they can get access to the production environment, they have to show that they are compliant from a security perspective and from an API implementation perspective. So for security, we basically use the standard OWASP, VASA testing, or whatever it is called, for that verification part. Now, on the NDHM side itself, in order to get the infrastructure and the scalability, right now there is a open source policy that the government has been pushing. And so much of the work that we have taken on so far is actually built completely on open source and open source components. But we do use, the actual cloud service provider, in our case, provides much of the security as well as the basic layers that do enable a lot of things for us beyond, before the open source layer kicks in.
Thanks.
Yeah, sure. If I just were to pick up points from what you said, Kiran, let me break this into parts, right? So there's going to be a platform where I, as the citizen, am going to be at the center. There's going to be the healthcare provider. There's going to be an insurance provider. There's going to be probably some equipment manufacturers. There are going to be pharma companies. There are going to be these street corner clinics. And there could potentially be some research establishments who want to pick up the data and do something. So I'm just looking at it as a 360-degree perspective. Yes. Now, as you look at this kind of a platform, you rightly pointed out, and I'm focused very specifically on two dimensions to this. One is the security perspective, and second, I want to qualify talking about the privacy perspective. Now, when you talk about security, there's no perimeter today, right? So you have the identity, you've got the connectivity, you've got a bunch of things. And there is, I would call it as very layered levels of security, that from a network level to a cloud level to an equipment level to a code level. So there are so many other dimensions to security that could come about, and you've got to define the standards for that. That's number one. And number two is, we talk about data, we talk about privacy, we talk about the PDP bill and GDPR equivalent and stuff like that. So we're talking about a lot of those things. So this whole concept about privacy, consent management, and the user's concurrence, the two-factor authentication that you talked about, the payment a lot, multiple times. Yeah. So where we have a two-factor authentication where this gets cleared and then you allow it. So how do you envisage these two dimensions happening in such a wide platform, where in some sense, like you talked about, it's more of a collaborative architecture rather than someone being able to control the whole thing. It's a federated kind of a structure. So how do you envisage this happening?
Yeah. So I think we'll talk about the privacy first, because there are certain concepts there. I don't know how familiar you are with the PDP bill, but the PDP bill essentially in India came up with this construct that there would be consent managers and digital consent managers. In fact, this was being first adopted by RBI. And so RBI has a specification that they call as the account aggregator specification, where for the movement of financial data between people who are creating financial data to you people who want to use financial data, you can go through this account aggregator, as they call it, to move it, right? So very similarly in NDHM, we are creating this concept that we call as health data consent managers. So these are digital entities that essentially help you manage your consent and move the data around, right? So one of the beauties of this architecture that we are pushing at NDHM is that if you take your software at a hospital or a lab, right? So the PDP bill is coming, and essentially the PDP bill is going to put a lot of demands on anybody creating any kind of data with privacy or with personal data to essentially add other layers of protection. So by making yourself NDHM compliant, we are going to essentially say that, look, you're definitely going to be compliant with PDP. And that's one of the benefits for to kind of move towards adopting NDHM compliant software as they kind of go along. So what this actually architecture does, Shri, is that there is a construct that MIT has pushed out called the consent artifact. So a consent as per the PDP and as per this consent artifact has to be very specific. It's like, what is the purpose you're sharing the data? What data are you sharing? How long can the other entity have the data? And there is a electronic format, including a digital signature that can accompany it, which actually captures your consent in a way that is legally, usable in, say, in a court of law, right? So it has also got a fiduciary and this one responsibility. So it's got a non-repeatability aspect to it. And essentially, the way we move this around is that when you get this consent artifact, you are able to then use that consent artifact to get the data from wherever this user's data is held. So if I'm fetching data from a lab, I will have to provide the consent artifact to that lab, and the lab looks at it and says, okay, this is Sridhar's consent, and therefore I'm releasing the data, right? So that's the way the privacy bit is being architected. On the security bit, security is definitely more complex, and that is going to be done primarily through two steps, right? So one is anybody participating in the ecosystem will need to get themselves to a certain level of security. So today what happens, many of the implementations in India, and especially smaller setups, security is like an afterthought. They will put up the software, they'll go live, and then they'll say, okay, when the first breach happens, we'll take a look at it, right? So our approach right now is to say, okay, look, you are going to come on to the NDHM ecosystem. And if you're going to come on board, before you can do that, part of the compliance requirements is that, okay, where do you stand on security? How have you this one? So you will be subjected and will need to pass an audit based on a bunch of standards. So the only way we can secure these and get these overall ecosystem to a certain level, is to step through these standards. But we also have to play a role where the journey has to be a journey. I cannot suddenly walk into somebody who's running a business and saying, here is throw the book at them and say, okay, here's this big list that you have to comply with, because then he will not even join. He'll say, I'd rather be in my current world rather than become part of this, right? So it is a journey, and we are taking this as a journey. And so we are looking at what is the current maturity and maturity levels, and how do we actually then slowly improve the maturity level. So we do look at NDHM as a program itself as a more of a decadal program. This is not tomorrow morning we have to get this done for you, right? But this is really goals, but do the architecture in such a way so that it actually benefits our whole society for the next 3 decades.
So Shri, I'll maybe, I think looking at the time also, I'll take a lead from there. And Kiran, as you said, I think it's a journey, and you definitely spoke about in terms of security aspect, compliance aspect, and the platform aspect of it. I think something more from policy in terms of understand what are the plans for universal health coverage, which is goal of NHA, and then obviously nationwide coverage has to be there. So one is 2 parts to it, plans for universal health coverage. Second is, how do you see the role of technology companies like us, which can play maybe key part to this? So your views on both the things.
Sure. So, I mean, the National Digital Health Mission is a technology initiative. So, we are not going to go very far without the support of technology companies of all forms, shapes, and sizes. Anybody who's providing anything in the healthcare space is going to have to at least be touched in some way or the other as we kind of go along. And I do think it is also a point where we think the time is probably right, where we were going to see significant investment into this space by organizations. I think the pandemic has shown one thing, that digital is important. If you see the shift towards teleconsultations, if you even see the shift to how doctors are now saying, okay, on WhatsApp, they're looking at reports, making decisions, right? So one thing that would have essentially done is the pandemic has essentially raised the importance of digital within the healthcare delivery ecosystem of India. And so it is unlikely that you can meet a hospital today and the hospital is either not aware or saying, okay, what would happen digitally? So while there have been a lot of visions projected on how digital healthcare will be, I think one thing that we can all thank the pandemic for is that the shift is probably has been accelerated in many ways. Universal healthcare is not a pure technology problem. Delivering technology is going to be an important enabler for the universal healthcare process, but it's a much bigger problem in terms of actually financing, healthcare financing, and actually policy in terms of delivery. We do think that many of the building blocks that we're putting together, specifically a building block that we're putting on health claims, is going to be very key in being an enabler of UHC. Because one of the things, if you look at the current payer segment of insurances, India processes about 2 crore claims, health claims, most of them inpatient claims today. The average cost of processing the claim is over 500-600 rupees. Compare that in UHC, you will need to cover an OPD claim, which is just a visit to a doctor and some medication. And that itself may be only 300 rupees. So you cannot have a claim processing system that's at that and say that, okay, I'll find a way to kind of process this. So digitizing that journey and making sure that the costs are down, far down from where they are going to be very critical in being also enabling UHC. So I think that would be the list of what you said. Sorry about that. Yeah.
No. I think.
Thank you, Mr. Kiran. I think it was really enlightening. Shri, over to you for something.
Yeah, I think we can just keep going on and on about this, but quite frankly, Kiran, like always, you managed to keep it so simple. But what we take away from this is that clearly technology is from the bedrock, and we all have a role to play, and we aspire for a significant role there. But I think the number of dimensions that you talked about, in terms of not just a medication, but an insurance and a claim processing cost, it just shows the extent of thought that has gone behind this, and the kind of platform services that we can enable from this. I think sky is the limit, and thinking about it in a 3-decade framework, I'm glad we'll leave behind something solid for our future generations. Thank you so much for your time.
I hope so too. Thank you so much, Sridhar, and I hope the National Digital Health Mission will touch all of our lives within the next 2 years, and I do hope all of you stay safe, and this pandemic will be over for us.
Yeah. Thanks for your time.
Quickly.
Thank you
very much. Back to you.
Thank you, Shri. Kiran, Anandampillai, Advisor Technology, National Health Authority. And thank you, Sridhar. Thank you, Shri Prashant, for this interesting fireside chat. And we got a lot of information and insight about National Digital Health Mission, and we really look forward to it. And now I request and invite Shri Rajesh Avasthi, Head of Cloud and MHS, Tata Communications Limited, and Shri Andy, Senior Director, Cloud Solution Architecture, APJ, VMware India, for the presentations.
Hi, Pragya. Hi, everyone. I hope I'm audible and all of you guys are safe. So I have with me Andy from VMware Asia Pacific team. We have a small presentation, although whatever we wanted to present has already been spoken by Kiran. But we thought, okay, we'll try and show what technology platform has been enabled to make some of the things which Kiran stated in his speech when the panel, the fireside chat was going on. So I'm going to share my screen where I'll show you some of the slides. So both Andy and I will run you through some of the charts that we have. I hope this is visible to all. So what we have put across is some of charts which is going to talk about how embracing digital governance has helped during the pandemic and beyond. And this is something which has been done on something which is called as Government Community Cloud as per MeitY empanelment of cloud providers. So we are one of the empaneled partners. This is a VMware verified cloud platform from Tata Communication. This is only for government and PSU customers. So it's a physically isolated environment which is created only for Government of India, government departments and PSU customers only. So that is what we have done. But before we start there, I think what is also important is to understand what is the digital health vision when NHA was created or National Health Advisory was created. So it was to create e-health records of 1.3 billion people across India in a secured manner, basically. So it would become a repository which would be set up pan-nation for connecting with various hospitals, as Kiran was talking about, where if something is required from a telemedicine network perspective, it is shareable between those environments. It is also going to be used for optimal usage of IT for pan-nation surveillance and monitoring of various programs. So one of these such program was Ayushman Bharat, which was something which was launched on this particular platform. And if there are others which would also come in due course of time. It was to use efficiently the IT tools for the capacity which is required for such a scale when we are talking about, and also look at wide-scale deployment of IT tools from a governance and information dissemination perspective. You already heard from Kiran stating that security is the paramount, or the privacy of the information is paramount when it is in the full scale. So if you look at what are the National Digital Health Blueprint roadmap or a vision which was envisaged. As we highlighted, we stated it is going to be extensively deployed digital tool for improving the efficiency and outcome of the healthcare systems in country, and it would ensure the range of care and governance which could be given to the people of India, and kind of becomes a single umbrella for creating a repository of healthcare services in India. And some of the principles which were brought in was that we should put in an environment which should think big, where we should incorporate all the citizens of country. It may start small, but scale up fast. So that was one of the requirement which was there. From a requirement perspective, it was also important that all the digital health records are put on an infrastructure which is robust and is always available. Creating a citizen consent based personal health record was something which was getting created as part of this platform. And there are other things also which were taken into account, which was promoting healthcare data analytics and medical research, looking at information systems which are already existing in the healthcare sector, and how do you integrate that. And that's what Kiran spoke about, API based integration with various systems which was there. And what was built was a building block which was used for identification, which was the personal health identifier, and the health master dictionaries and registries, which was put in as part of that. Citizens come as the focal point of this, which is where we are saying that citizens to be in control, basically the consent managers as well as privacy operation centers. Service access and delivery was to be omni-channel, so that it is addressable to the larger set of people, and interoperability between various systems from various hospitals and systems which are coming in, and national health informatics standards become the part of that interoperability. 5 layers of infrastructure, data hub, tech, app building, blocks, access and delivery. So these were some of the things which were taken care. And this created the pillar for National Digital Health Blueprint, or NDHB, basically, which is what the blueprint was created. But when this was being created, and these are some of the pointers which are here, what were the challenges and complexities when such an implementation was to be done? One, the repositories were scattered. That means you had data coming in from siloed platforms, some from government, some from private. Within government also coming in from different data centers like NIC data centers or non-NIC data centers. And being used by various government ministries and PSUs to create this data, basically. So that was one of the requirement which was there. As Kiran highlighted, security and compliance was very important because information was coming in from different sources and API-led integration was to be taken care of. I think from a application platform onwards, those were things which were embedded in the application itself. Integration and interoperability was very important because this is not going to be a single database as Kiran stated. It would be a repository of databases which are interconnected with each other. And that's where this interoperability and integration was very important. So one of the things which was required was that the IT infrastructure should not be rigid. That means for such a program, they were not sure that how much scale would come in because it was to start small and then scale fast. So no one wanted to invest capital and keep it waiting for some time. And that's where looking at a non-traditional way of infra management was very important. And that was very much required as a requirement from them. And improper communication channels, discrete and multiple communication channels were available from various government mission projects for citizens and also from various other policy databases which were available. So these were some of the challenges which were there. So when we worked with NHA, we said that we will create a robust system which will implement as the population scale comes into this environment. So we stated we will look at creating a platform which is citizen-centric and is driven by the vision which is created by NHA. Look at e-inclusion for all the channels of delivery which were coming in. Look at a digital infrastructure as the core for every citizen who's using these services, along with the security and privacy. And all this on demand and governance on top of that. So basically what we were looking at was an open system, which is highly integrated and is participatory. So you're not saying that everyone was given a mandate that you have to do it also. So it was basically powering e-transformation, which will look into breakdown of organization silos and create a horizontal whole of government structures, basically interoperability through the API-led connectivity. So that was something which was taken into account. And some of the trends which empowered IT version 2.0 was cloud computing, open data initiative, and wherever appropriate in due course of time, look at Internet of Things. So these were some of the things which were taken into account, which will ensure what? Basically a digital governance, which is implemented on this environment. So what we looked at was to manage the complexities of scale, look at easy continuous application development, which is where some of the applications were cloud native applications deployed on containers. And there was a close working between the development and operations team. So that's where DevOps come into play, and creating CI/CD pipeline automation was something which was taken into account. Speedy delivery was very important because one of the principles was to start small and then scale very fast. So speedy delivery timelines was very important, and assuring that performance meeting the stringent SLA requirement was one of the things which was there. As part of the solution, what we gave was a performance assurance with the robust core, which is built on the GCC, which is a VMware verified cloud platform as per MATI empanelment. Agility coming in because of the new services based on the containers orchestrated through Kubernetes, and having DevOps and CI/CD automation. Reliability coming in from integrated security and disaster recovery, so that this environment is available. From an efficacy perspective, there were various services which were taken related to network, security, containers, and giving a single pane of glass was very important. And what was also important was assurance that the mission mode delivery model plan is met and steady deployment is done before the launch happens. And that's what we worked along with NHA team in this particular. Now getting a little deeper into what government community cloud is. It is an enterprise class infrastructure platform. In this particular case, tuned for healthcare IT ecosystem. So it's an on-demand scalable capacity which is available. So you had production VMs with capacity on burstable VMs which was available. And this was built on compute, storage, and network, where we used some of the inherent technologies which were used by some of the largest enterprise projects in the government space from VMware. So we used vCloud Director, vSphere, NSX from a NFV perspective. Those were certain things which were incorporated, and all this was orchestrated through an orchestration layer, which was available with the self-service management console for the team. But when we were working on this project with NHA, we also worked as a MSP. So it was an integrated services coming in from our side, which included the cloud service provider services, which is the infrastructure services, along with the managed services. So it was a single point of accountability, both from infrastructure and manageability perspective. That is something which was given as part of that. What we also gave was freedom of choice. We said, yes, the objective was to have as much open source technologies available. So we gave options on various operating systems. From a network function virtualization perspective, as I stated, it incorporated the NSX, which included the zero trust networking, micro segmentation at the network side. So that was something which was incorporated as part of that. And from a storage perspective, there were options for block, file with IOPS commitment, as well as for long-term retention object-based storage options being available for both DC and DR. So this was something which was delivered as part of the services. All this was orchestrated through the self-service management console, which gave user management, environment creation, also gave inputs on the showback and chargeback, as well as reporting dashboards. But not only that, this self-service portal or a console which was available could also integrate with the dedicated infrastructure if it was required, or also work with the public cloud providers like AWS and Azure. Although this entire environment was created on GCC, but from a capability perspective, that was something which was available. So it was a hybrid environment that seamlessly integrated with other cloud providers also. So that was something which was built in as part of the integrated cloud, which was delivered as part of this. But what was important, as I highlighted, it was a fully managed cloud from our side. So one of the things which was taken into account was that it is aligned with the ITIL best practices for IT services management. So we had integrated IT services management workflows for cloud and the dedicated infrastructure, which did the orchestration for the platform or the operating system, and also making sure that it was a fully managed environment. All the auto ticketing for all the changes and updates were stored in the CMDB, so that if there was an audit which was required, we had audit logs for meeting the customer compliance requirements. So it meant that it was a fully managed environment with platform services which were meeting the customer requirements. So these were certain things which were taken. So here I will pause and I will invite my friend and colleague Andy. If you can give some more insight on some of the VMware technologies like vCloud Director, vSphere, or NSX, how that helped in creating this government community cloud requirements which were called out in earlier slides, as well as what Kiran stated about that.
Sure, Rajesh, you already covered it quite well, and I know we are running out of time, so I'll keep it really short. One of the beauty of the platform was Tata Communications leveraging the cloud verified, which leverages the enterprise class industry standard vSphere based infrastructure, as well as leveraging NSXT, which brings in things around zero trust security, which makes sure, along with microsegmentation, which makes sure that no two tenants on the platform impact each other, maintaining a very strong data security. We heard Kiran talking about this idea that security and privacy needs to be something that is built in from ground up from day one. And this is a platform that naturally brings this to the table. And this is something that is a platform that is leveraged with 70 plus cloud verified partners, Tata Communication being one of our premier partners leveraging this technology. So it's a very proven technology that makes it very ready for government community cloud. Back to you, Rajesh.
So I'll move on and maybe hand it over to you, Andy.
Sure, and I'll take just a minute on it. I get a message that we are almost running out of time.
Yeah.
One of the most critical things and the exciting thing about this platform is the fact that we have extended vSphere as a platform that converges the modern technologies. You've heard of Kubernetes and containers along with VMs, all bringing together into a single platform. So it's a common platform that is used by developers using Kubernetes APIs to access data center infrastructure. That's software, compute, storage, and networking. And on the other hand, IT operators using the vSphere tools that they're very familiar with to deliver Kubernetes clusters for developers. So it's bringing best of the both worlds. It's bringing the DevOps world together without having to break what has already been built in the past, allowing developers to create new sets of applications, new experiences, all the while improving the economics by converging vSphere, Kubernetes, and containers all together in one place, ensuring that you still have the same industry-grade security and privacy infrastructure, as well as the single pane of glass available to all agencies leveraging these platforms. Back to you, Rajesh. We can probably skip the next slide.
Yeah, so one of the things which we also took care of was that we had integrated security and controls on this GCC environment at all the levels. That means at the infrastructure level, so all the firewalls and the zero trust networking, which Andy spoke about. Also incorporating at a host level that we have host intrusion prevention systems, anti-malware systems, which were taken into account. From a Kubernetes environment perspective, having capabilities to support DevSecOps. That means you have integrated access management in form of PIM and PAM. So all the management which is done on this particular platform by Tata Communication engineers, they come through a privileged identity access management environment. So any changes which they are doing on this environment is something which is registered in the audit logs, which I spoke about. And it came along with the layer 7 DDoS protection, which was required. And at a data level perspective, there were options like HSM was something which was taken up. Encryption was something which was used in some of the volumes, and DLP was something which could be taken into account. So all the security controls were taken as part of this. And all this was integrated with the 24/7 monitoring, which was happening on the SOC, which included the SIM, SOAR, and CTI platform from Tata Communication perspective. So looking at the time frame, I'm going to not going to talk about what all we did. Basically, we have a dedicated team which is working on GCC customers only for government required. These are certified professionals, scalable expertise which is available. Hybrid solution is something which was incorporated. We made sure that all the security and audits, all this environment GCC which is created is audited by METI, STQC for all these security controls and meeting the guidelines which are identified with them. And resolute commitment, which is the leadership connect at all the levels coming in from Tata Communication and NHA, that was something which was done, committing for all the government projects that we were taking. So with that, I'm going to end our presentation. I'm not going to go through a couple of more other slides which are there, but pretty much we have covered. We have done this for NHA. We have done it for some of the other government customers also, apart from the private sector. And we believe that this could be a good technology platform which could be used for such citizen services projects which are envisaged by government and PSU and other departments. So back to you, Pragya. I know we are a little over the time, but we thought we'll close it at this point.
Yeah, sure. Thank you so much, Rajesh. Thank you so much, Andy, and for the wonderful presentation and very sound technology insights. Now we are moving to our power-packed panel discussion on transforming digital health during pandemic and beyond. So we have Shri Sunil Kumar Bhushan, DDG and Head Health Sector National Informatics Center. We have Shri Abhishek Kumar, Director IT, National Health Authority. We have Shri Dr. Sanjay Sood, Associate Director and Project Director, e-Sanjeevani CDAC. We have Shri Choudhary Mohammad Yasin, Mission Director, Department of Health and Family Welfare, Government of Jammu and Kashmir. We have Dr. Nipun Jindal, Mission Director, NHM, Department of Health and Family Welfare, Government of Himachal Pradesh. We have Dr. Adesh, Kang, Director, Family Health Welfare, Department of Health and Family Welfare, Government of Punjab. We have Dr. Heera, Additional Mission Director, National Health Mission, Government of Uttar Pradesh. We have Dr. J. Ramesh, State COVID Nodal Officer and SNO, NCD, NPHCE, NPPC, Government of Puducherry. And we have Shri Rajyashree Purkashtha, Head of Pre-Sales India, MECAA, SAR Tata Communications, and moderator of our session, Shri Prashant Choudhary, Director, Government, VMware, India. I request all of the eminent speakers to keep their cameras on.
Sure. Thanks, Pragya. And I think it's a privilege to handle such a panel of esteemed speakers here. So I think without wasting more time, I think Sunil sir, you have to go into a next meeting. So I think the first question over to you, sir. And I think I'll start with, we talk about NDHM program, we talk about technology, which can be used over there in our earlier sessions, in the presentations also. So maybe the pointer which I want to bring to you is how COVID-19 has accelerated digital transformation in healthcare. Your views, and maybe you want to also cover the current state of digital health right now. So if these two aspects you want to cover before you move to your meeting.
Am I audible?
Yeah, absolutely.
So let me explain what we have done at NIC as far as COVID applications in healthcare are concerned. NIC has not only contributed in healthcare, but also contributed in government function and public service delivery, which was not possible because of the intervention of the technology. So if I categorize all my NIC's initiatives, so I can categorize them into 4 parts. First is basically for applications which were primarily related to COVID-19 management, and second was related to information delivery, which was very important from a citizen point of view. And the third was public service delivery, and fourth was internal functioning of the government. So we almost contributed as NIC, contributed almost on every aspect of it. So if I look at COVID-19 management related applications, you see Government of India, Ministry of Health and Family Welfare came up with COVID-19 India portal, that is popularly known as S3, Special Surveillance System. So that was basically, initially that was the positive cases were being entered into that portal. So what we did, government, we worked with the EG9 group of the Empowered Group 9 of Government of India, and basically we integrated the S3 portal with ICMR database. So whatever positive cases were coming in ICMR lab management system, that was integrated. Those cases were not being entered into S3, but they were integrated through API, and the data was now data is coming from. So ICMR database become one of the single source of truth for COVID-19 positive cases. That was the first assignment we did. And then we strengthened because the load was increasing in ICMR. So there was a requirement of huge infrastructure, and scalability was required at that point of time. So we assisted the ICMR in scaling the application and the infrastructure as well. And then came the Arogya Setu. I think I need not to say anything about Arogya Setu. Everybody knows. And the NIC expanded that software as a contact tracing application to basically information dissemination. And now it has been integrated with the COVID application also. So with this kind of scale, I think Arogya Setu has come up well with the citizens of this country. And again, NIC developed RT-PCR sample collection software, and that software basically it's a mobile application where the collection points it is being used there, and the all the information about the patient whose sample is collected. So RT-PCR app is used, and this app is integrated with lab management system of the ICMR. So the challenge was to integrate the applications which were basically silos in nature. Now they were integrated using APIs. And apart from this, as you know, one COVID dedicated hospital came up named as Sardar Patel COVID Care Center and Hospital in Chhatarpur. So in that, basically, we customized our e-hospital application to the functioning of that particular functioning of the that hospital, and now it is also being used. And registration, admission, treatment, transfers, discharge, all the functions are being used by IDPP doctors. So apart from this, we developed a small telemedicine solution which was well integrated with the e-hospital. So it was primarily used in Uttarakhand. So it was a small solution which was used by AIIMS and New Delhi also. So this was more about the COVID-19 management applications. And if I see information delivery software, so when you go to mohw.gov.in, you see numbers are changing every day. So at the back end, we have been working with the S3 portal and getting the information for displaying it for purpose of consumption at various levels. And apart from this, various stakeholders like hospitals, like doctors, like citizens, the information categorized was done on the website, and proper information was made available to the citizens so that they can follow the protocol as per the direction from government. Apart from this, we have ORS online registration system where basically we give appointments and everything, and that was also strengthened so that whenever people come there, they get the proper information about the COVID functions. Apart from this, and the third category was public service delivery, where we paid payment to the citizens, like especially DBT payments. Scholarship was released, and on 14th of May, 19,000 crore has been disbursed under PM Kisan. Honorable Prime Minister has released that, and it was released for 9.5 crore beneficiaries. So this would have been possible because of the technological solution developed by NIC. So many programs, Manrega, PM Kisan, and this NSEP, and this Pradhan Mantri Matratva Vandana Yojana. So all the payments to the beneficiaries, they were made using the under benefit transfer.
And I think it gives us a clear, insight. And
fourth one is government management functioning. Yeah. So where we have basically provided the video conference services to all, to President Office, to Prime Minister Office, to CM Office, to Minister Offices. And apart from this, all the work from home was possible because of e-Office solution from NIC. That was used by almost all the ministries, and PFMS solution from NIC made possible the financial transaction made by the government. Apart from this, we have work from anywhere portal also that was launched during this period, and we have various users are using that. So let me stop here, and I have basically again saying they have categorized the whole application into four parts. One is COVID-19 management application, information delivery solutions, and public delivery, public service delivery solutions, and government internal company solutions. Thank you very much.
Thank you, sir. Thank you for being us, and I think you gave us really.
If there is any question, so I can take up that. Otherwise, I have to leave.
Sure, sir. Thank you. We'll come back to you offline, sir. I think we have questions for you. So I think with this, I think the insight which Mr. Sunil has given, Abhishek, sir, I'll definitely like to come back to you where NHA is the leading implementation agency for NHM program, working with various agencies and departments. Mr. Sunil just gave a glimpse in terms of all other applications as well, but I think we'd like to hear from you how COVID-19 has accelerated digital transformation in healthcare from your perspective. Abhishek, sir.
Thank you. So as on date, we are doing NDHM, National Digital Health Mission Project, and it is very much related to condition induced by COVID. So how it has been induced by COVID, as we know, because of COVID, people tend to avoid physical contact and for right reasons. So naturally, importance of tele-services or tele-health services have increased a lot. But if we see the condition of tele-health services in our country, we are not in a very advanced stage, or we are not in a very good shape. And there is a reason behind that. What are the fundamental reasons? First, for creating a digital health ecosystem, we need a system of identifiers through which all the stakeholders like individuals, healthcare professionals, facilities, labs, hospitals. So each and every stakeholder involved in the healthcare system needs to be identifiable in the digital health ecosystem. That is the first requirement. Second is that the digital system has to be an interoperable ecosystem. That means common standards have to be used. So unless these two conditions, the use of common set of identifiers and the use of generic or common health data standards, these two conditions need to be satisfied. Only after that, digital health ecosystem can be established, and on the top of that, various telehealth services like telemedicine, teleconsultation, etc. can be enabled. So through National Digital Health Mission, we are trying to address these twin challenges, and on the top of that, various value-added services can be provided. So we are building a system through which health ID can be created by anybody. We are building a healthcare professional registry. We are building facility registry. We are prescribing health data standards which can be adopted by players in the ecosystem. So basically, these key elements of National Digital Health Mission will create a basic infrastructure or basic framework. On the top of that, there can be revolution in terms of telehealth services. So this project, you might be already aware, was launched last year on 15th August. As on date, it is operational in 6 union territories. And obviously going ahead, the geographical area and the scope of services are going to be expanded. And this COVID pandemic has definitely accelerated the pace of implementation, and everybody in the ecosystem, be it individuals or healthcare professionals or facilities, everybody has come to realize the importance or significance of enabling tele services. So that way, NDHM is going to bring a transformational shift in the digital health ecosystem of the country. So for the time being, I will stop here.
Sure.
And if there are any questions, we can take it.
Sure. And sir, you before I go to Choudhary sir from Jammu and Kashmir, so I think there were two important points which you highlighted, that each healthcare worker need to be identified in the health system, and I think there is a need to have common standards within the health system so that interoperability can happen. Choudhary sir, I think I'd like to hear from you in terms of how do you feel that digital transformation has accelerated in healthcare from your perspective?
Yeah, thank you, Prashantji. So, of course, as Abhishek ji, identified that COVID has indeed accelerated this progress, and we have had things like from Arogya Setu to a whole lot of other apps and IT tools brought in both at national level and state level to enable us with the same. Because obviously the need was to ensure that mass surveillance is done in a structured manner where it can be tracked as well, and especially because it was on such a large scale that these exercises were being conducted. However, these developments, in my opinion, have taken up in short bursts and in their temporary nature of sorts. As in, we've seen how Arogya Setu was, it was launched with a big bang, but later on it kind of dashed down, and we just need something more permanent which can incorporate all the major developments as well as be adaptable to local states and UTs in terms of their customizable needs. Now, when we talk about, say, a platform which can provide universal health coverage in terms of say a database of health record of all our citizens, as well as how they are being tracked over the course of the future, I seriously think that it should have 4 features. Firstly, that it should be constantly updated, and for that it would require that it must be respected and followed by all stakeholders, all union and state governments, as well as departments and other bodies which are within our health system. Secondly, it must be accessible from multiple points. So because a person is not necessarily accessing healthcare in one area or region, he's going to multiple hospitals, while some other clinic or some undertaking some teleconsultation. It should definitely have respect for the individual's privacy, and but more importantly, it should have, as Abhishek ji said, a set of common identifiers which will have a series of, which will enable a scope of flexibility within the system, and that would ensure some sort of customization at state level itself. Why I say this? Why? Because, for instance, in the ministry, in the Ministry of Health and Family Welfare, IT tools are already there, a lot of them, and they're pretty good. I mean, in fact, they were one of the first ministry to initiate use of IT tools, and we have historical portals like the HMIS or the RCH, and now we have Anmol, RCH being shifted to Anmol, and further with Ayushman Bharat we achieved digitization of health insurance disbursement as well. However, the next step would be integrating all of them so that each of their roles in the kind of health chain is fixed, and they feed into each other. Say, for instance, I am very optimistic about Anmol ANM Online, because we were generating huge volumes of RCH, reproductive and child healthcare data for our for many years, but it was not actually getting access to the higher level because it was all done manually, right? And there were no inferences being drawn, there were no alerts being given. So digitizing it is enabling us to further work on that particular data and make inferences from it. And there's something else we are trying in JNK, and I'll give you an example. We are trying to come up with an app for RBSK, the Rashtriya Bal Swasthya Karyakram, where the health record of the school-going children will be updated by the teams which we have dedicated teams in each health block to do so, and that will kind of become a basis for the individual health record, which can then be further fed into, say, something else which NDHM might come out with the future. So broadly, these are the areas where I see our digital health structure evolving. Thank you.
Thank you, sir. And Dr. Nipun, maybe I'll touch with you right now. And I think 3-4 points Choudhary sir said, that one is data should be regularly updated and it should be accessible. There should be common set of parameters. And finally, he said integration is the key. So your views, sir, on digital transformation and healthcare.
Thank you, Prashant. First of all, I would like to thank the organizers for having such a rich panel for discussion today. And I can see Dr. Sood from CDAC is here. He has been leading the e-Sanjeevani portal throughout India for the past 1 year. And I have my colleagues from NIC who have been working very hard on this RT-PCR application of India. So healthcare as a whole, it has seen a lot of transformation and innovation in the last 2 decades. But coming to the last 1 year, the COVID, this pandemic has presented many opportunities. And with it has become the sort of epicenter of global attention, the healthcare system. And definitely IT services did not only provide a lot of, I would say, solutions to many problems, but it also garnered the attention of all the public and private sector units which are specializing in ICD communication, basically. So this is because I would like to say that many young policy makers, they are donning important position in implementation and policy making as well. And technology seems to be the first recourse for any problem that is encountered by them. So this has shown that the COVID pandemic has brought many new initiatives to the fore, and I would like to quote a few of them: the COVID portal, the latest example in vaccination, the e-Sanjeevani application, the RT-PCR application of India. So this is bringing technology in a big way to in the forefront of the public policy and implementation. But I would like to also say that we are all doing these in silos. We are adopting a piecemeal approach. As I would say, my counterpart from JNK has also mentioned that there needs to be a system of unique identifier and integration of all these health platforms. So I would like to, I feel that one of the important challenges in this aspect is the decreased accessibilities to APIs. So basically, if we want an API of any application, we'll have to write to the ministry, they'll communicate back to us. If I like to quote an example, the Health and Wellness Center portal and the NCD application, it took almost 1 year at the ministry level to integrate if it was implemented with the same ministry. So this is one of the biggest challenges. And the state specific customization, it should be very flexible. So the main I would like to say the advantage of this digital technology is flexibility, but due to these rigidity in the system, in the government system overall, so we are not able to harness the flexibility which the IT platforms they offer us. And during this period, the cost saving has been immense. We have been seeing the TMS of the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana. It has been able to plug a lot of ghost beneficiaries, a lot of pilferage from the system. So this meet we are having virtually, if it were a physical meet, it would have costed lakhs, if not crores of rupees. So this is the trainings which we have been carrying out during this COVID pandemic. They have been virtually free of cost, and the cascading effect, the accessibility of the general population, including the healthcare workers, to those trainings, it is immense. The true picture, the RT-PCR application of India, it is a very good example of that. The true picture of the number of tests which is being performed at any given point of time in any given state or a district, we can see from that. And so we have been developing apps statewide also. I'm sure many of my colleagues, they have been doing this, from simple apps like data capturing forms to complex algorithms they have been developing. So all these we are virtually we are just ad hoc. These are basically ad hoc solutions to the problems we are encountering. So NDHM is a very good hope, I would say. And the NHAs, I'm sure they are working towards providing a basic scaffolding so that the additional building blocks, they can be built on by the states or by the center or anybody who is willing to give IT technology a go in this healthcare sector. So this is all I would like to say. And I am sure that the upcoming times, in times of NDHM, they would be very exciting in terms of the IT applications. and they were really helpful in increase the public service delivery in the healthcare sector, as well as the decreasing the information barriers for the public as well and for the healthcare providers as well in terms of public policy making.
Thank you, Dr. Nipun. And I think one point which I think you also emphasized on is the need of integration. But at the same time, I think you highlighted the challenge that if it takes 1 year for integration, then I think the purpose is defeated. So maybe it is time for us to look at modern architectures, new architectures for application, the way we implement. And I'm sure that is happening right now. So, and you, I think, bear with me, Dr. Heera, Dr. Adesh, I'll come back to you. But Dr. Nipun mentioned e-Sanjeevani, so I have to definitely go back to Dr. Sanjay, who has been part of this project, and your views, Dr. Sanjay, on from a digital transformation in healthcare.
Thank you very much, Prashantji. At the outset, I would like to thank the organizers for putting together this panel on a very apt topic. And then I would also like to seize this opportunity to thank my superiors in the states like Dr. Jindal ji in Himachal Pradesh, Dr. Heera Lal ji in UP, and Dr. Yasin Choudhary ji in Jammu Kashmir, and Dr. Kang as well in Punjab, because it is their blessings that has enabled the masses to have a newer, I would say, gift of digital health, wherein it is primarily, we can say that it has been backed by COVID-19. It has got accelerated just because of COVID-19, because traditionally healthcare has been seen as a domain which is termed as laggards in adopting IT infrastructure or IT applications, but and then that could certainly be proven, or rather related with the way the healthcare delivery system, the stakeholders in the entire healthcare delivery system, starting from the policymakers to healthcare administrators to practitioners, and even the patients, the way they have adopted the application, the telemedicine application, e-Sanjeevani. Dr. Kang would certainly acknowledge this, that way back in 2006 and 7, we implemented statewide telemedicine network in the state of Punjab. We also did that in Himachal Pradesh. But then in last 5 years, rather around 7 years, we had not been able to get around 50,000 consultations in those 7 years. But as far as now e-Sanjeevani is concerned, primarily because of COVID, because COVID has accelerated the need for having digital health, or the importance of digital health. Every day we are doing around 45,000 consultations, which shows that the way digital health has been adopted by the entire healthcare delivery system in the country, including the patients, and that in itself is a huge testimony to the fact that COVID has accelerated digital health ecosystem in the country. And as regards the current state of digital health, when we say that e-Sanjeevani has already served more than 5 million patients, we can, and if we look at the way it has been adopted, we have patients who've been the age group of the patients who have sort of used e-Sanjeevani ranges from 1 year to 100 years. And that is what reflects that it has been adopted, or it has penetrated into the patients or the public, that each and every age group understands the importance that that a modality like telemedicine holds for them, the value that it adds to their lives. Besides that, we have also experienced that e-Sanjeevani, if we look at the utilization in the districts, it is the tier 2 and tier 3 districts which have taken lead in utilizing e-Sanjeevani, like Salem in Tamil Nadu, which is not really a big or a very popular district, then Hassan in Karnataka, and Meerut and Raebareli in Uttar Pradesh. These are the leading 4 or 5 districts which have overtaken other districts, bigger districts which are more popular, like Thiruvananthapuram or Chennai, or those IT literate, the districts with IT literate populace. So this reflects that the current state of digital health in the country is such that it has penetrated to tier 2 and tier 3 cities as well. And as far as the challenges and the opportunities those we faced, we understand that initially when e-Sanjeevani was designed, it was conceptualized with a view to have one general OPD per state, but it is the I would say, the promising nature or the potential that the policymakers in the states, they realized, or they could see in the telemedicine platform, that they requested or they wanted concurrent specialty OPDs to be launched on e-Sanjeevani portal. So to start with, we started with the idea of having one general OPD per state, but now we have 350 OPDs across the platform, and around 300 plus of those OPDs are specialty OPDs, and we also have tertiary level or rather super specialty OPDs on e-Sanjeevani, like pediatrics oncology or radiology oncology, and things like those have started adopting these modalities. And we can say that which was earlier being seen as a challenge, the adoption of IT in the healthcare delivery system, is now leading or opening doors to newer opportunities, where the specialties I just talked about, we had never dreamt of having those kind of specialties also using modalities like telemedicine or e-health or teleconsultations. And then besides that, we've seen that in few states, Himachal has been planning about having e-Sanjeevani in old age homes, in orphanages as well, in prisons as well. In Kerala, they're already using e-Sanjeevani in prisons for the inmates to consult doctors without having them to be taken to the hospitals. So these are the opportunities which have spun out of the initial challenges which everybody was looking at, modalities like telemedicine. So with this, I would like to close saying that healthcare is no more health sector is no more a laggard in adopting IT, and COVID-19 has played a very important role in bringing about this huge transformation in the healthcare delivery system. Thank you very much.
Thank you, Dr. Sanjay. And I can only say thank God to technology. I think we have been able to leverage, and where we are without technology, we will not be able to support so many people who need this. So Dr. Heera, I think you heard how various states being done. Abhishek sir spoke about in terms of where it is, which direction it's going. So will you like to talk about from UP perspective?
Okay, thank you for connecting me over here. I was listening the speakers, no doubt about it. Almost topic has been covered. COVID has accelerated, and COVID is a boon also, and due to some procedural things we are not able to implement as per our expectations. One thing I would like to mention over here, in India, we copy the things without, in some cases, without the rationale, without the reasoning. So instead of making it beneficial, sometimes it's become harmful also. So one day I was listening someone, he was a learned speaker, he told in India, in Indian situation, we must use enabling technology in place of replacing technology. That is one point to be reckoned with, to be considered. We must use the technology in any sector, whether it is health sector or any sector, which may enable the Indians rather than replacing them, because unemployment increase in this situation. The COVID. Before COVID, we were using the technology in health sector, but COVID had accelerated the adoption and use of the technology, and COVID has made the people to understand the importance of technology in the health sector. So in this light, I would like to say, in health sector, we are running shortage of many things. We do not have the doctors, we do not have the nurses, we do not have many things required to run our hospitals or to provide the adequate medical services. So I would like to mention, or I would like to suggest that we can use this transformative technology in health sector, in remote areas, in to fulfill the gap of shortage of doctors, nurses, and other resources, so that a complete health sector can provide the required health services. Second thing I would like to mention is startup. Startup in health sector should get the promotion. So we should try to promote health sector startups as much as we can. One more thing I would like to mention, that analytics, technology-based analytics should be used at national level, at state level, as well as district level by the district magistrate and the DCs. The prediction by the data through the technology can prevent many mishappenings like the COVID phase second, can reduce its alarming situation. So if these things here, technology, we can use and we can provide by using technology in such areas, we can meet out the expectations of the public. Drone can be used in delivery systems. So in difficult areas, again, I would like to say, we should not use technology to replace our employment generating things. So these are few points which are in my mind, which I wanted to highlight, because it is transformation through technology in health sector. So these are the points which I wanted to highlight. Rest things have been covered, so repetition is not good at all. I hope so. Thank you.
Thank you, Dr. Heera. And Dr. Adesh, I think Dr. Heera spoke about, obviously, in terms of, I think it is given, everybody spoke about what role technology is playing in healthcare, but he mentioned that some of the innovative technologies are need of the hour to be used, like drones and AI analytics, maybe. So from your perspective, we'd like to hear from your views, ma'am. Mute, ma'am, yeah.
Good evening, everybody. Am I audible?
Yes, ma'am.
Yes, I heard all this, like speakers, almost everything is covered. What I would say is, like earlier, it was like, it's e-government and e-governance. We are basically going for e-governance, in which there is a two-way communication. And in many of our places, food license, registration, birth certificate, so on, many, like we have been using e-governance. It is, and especially in COVID times, like it's become more relevant in the sense whatever government wants, like the two-way communication with the citizens. Like how to put it, the like we have like consultations we started in our system. In that, like it's like kind of a very good testing time of our already going on technology. Like two-way communication, listen to the citizens, what they want, how to guide them. Like even if it is like a home isolation, like monitoring and guiding, there it is being used. So what I feel is that this is very good, but still like some more way to improve it, to get it. Like in many places where it is needed, the communication is not good, or illiteracy is so much, like those who actually need it are not being helped. I mean, they are not getting so much of advantage of it. Yes, many levels are not needed in this. It's a good way, like easier to get it in this. So what I feel is we have to give like some kind of how people assess it, how they get it, and two-way communication has to be improved much more and can be utilized in many ways. That's what I felt. Rest,
sure.
like
Thank you, Dr. Sure. Thank you very much. And Dr. Ramesh, yeah, I think as ma'am said, and I think Dr. Heera also spoke about, technology has to be an enabler, and Dr. Adesh also mentioned, highlighted, it is important to have communication both ways. It is not something using technology we created, but if the consumption is not happening, it's of no use. So your views, please, on digital transformation in healthcare. You're on mute, Dr.
Is it for me?
No, sorry, Dr. Ramesh.
Yes, please. Am I audible?
Yeah,
Sir?
yeah, it's audible.
Good evening, everyone. It's a pleasure to be amidst eminent group of panelists. My heartfelt thanks to the organizers for inviting me to the same. I'm primarily a physician. Also happen to hold a lot of positions of responsibility in the government of Pondicherry. Among other things, I'm also state COVID nodal officer and also in charge of NDHM program in the UT of Pondicherry. I look after various national programs, including National Program for Healthcare of Elderly, Palliative Care, and NPCDCS. I have seen a lot of my previous speakers going into a lot of technology. As a doctor, technology is introduced us when we join as an MBBS, and I realized a lot of digital technology is always useful in healthcare. From pre-COVID era only, digital transformation has been helping us a lot with respect to various national programs. In Pondicherry, we are pioneers in starting our own software to collect data about various chronic illnesses, including diabetes, hypertension, cancer, and other diseases as part of NCD program, even before Government of India came up with this digital program. We had our own software. A small outline about our union territory. We have 4 enclaves, as all of you may be aware. One is Puducherry, and the other 3 are almost rural or semi-urban. One is Yanam, near Andhra Pradesh. One is Mahi, in the borders of Kerala, and one is Karaikal, down south in Tamil Nadu. So, digital transformation is of great help for a UT like us, and ours also has a very good health infrastructure. We are almost 30 PHCs and CHCs, which can cater to the needs of health. Anybody has to walk in just about half a kilometer to 1 kilometer for any health care. And we also have 7 private medical colleges, as well as the National Institute of Health Importance, JIPMA. So health was never a problem in the UP, and digital transformation, whereas it's useful, one important issue we always felt was the infrastructure. Basically, the connectivity issue in some of the rural areas. In a place like Yanam, I'm in charge of NDHM. We have recruited enough health IDs, DigiDoctor creations, and health facilities. But there are a lot of fishermen areas in some of these rural places where connectivity is simply an issue. As some of my valuable predecessors said, having a digital system in place is one, making sure it is implemented for health delivery is altogether another one. So we need to really improve our connectivity on one side to make sure NDHM becomes a success. Actually, among all the union territories, we have found a lot of innovative ways to improve the digital health program in the form of creation of health IDs, DigiDoctor creation, and health facilities. We created nodal officers in all the peripheries, and we reached out to all the places, and we use all our government servants to enlist their own health facility, their own health IDs, as well as their family members. With respect to pre-COVID era, when the government of India started giving tablets and mobile phones, we used them using our ANMs, ASHAs, and Anganwadi workers to reach out to at PSC levels, door to door, and collected what we call as population-based screening. And definitely COVID has made a big difference. And post-COVID, WhatsApp as a social media has become a big useful tool for transforming knowledge with regard to COVID, dissemination of information, promotion of vaccination, and collection of data, as well as reaching out people for early symptom diagnosis and taking them to the hospitals. With regards to NDHM, we almost completed 50% of health ID creation in the UT of Puducherry. And may I request Ms. Pragya, I have shared quite a few slides with her. If she can display it here now.
Yes.
This is one way digitization helped post-COVID duty of Puducherry. We had created a COVID war room and we had created a COVID dashboard. We used the Step 1 platform to support the COVID real-time dashboard. What we used to do daily is we line list the number of COVID positive patients based on RT-PCR and RAT tests, and daily morning it is made available and it is converted to tickets and loaded on a digital platform. This is assigned to a screener. The screeners call, assess symptoms, give advice, and recommend the right action. The PHC medical officer then gets the data and he makes sure his team visits the patient and determines the next course of action. With this data available from the centralized platform, COVID care centers pick up the recommendations and act on it. Hospital team follow up the recommendation and act on it. And there is a separate home isolation team which picks up the recommendation and acts on it. We created an extensive network of home isolation teams as well as home COVID triaging teams. Using this platform, they reach out to the patient's homes and make sure the patient is not shifted out of the house and he is given a triaging there itself, whether he needs to be in isolation or he needs to be admitted. Next slide, ma'am. May I have the next slide, please? And this is how the workflow goes. The integrated disease service surveillance program sends daily line list of COVID patients. This is forwarded to our COVID war room. This is uploaded in the Step 1 dashboard, and we use our Anganwadi teachers and student volunteers who are assigned to specific PHCs to start contact tracing as well as case-based data collection, whether they have comorbidities, diabetes, hypertension, whether their sugar is high, what are the symptoms, do they need admission or they can be kept at home. All these details, once collected, will be forwarded to the respective PHCs and the doctors there will update the database with the recorded data. This is uploaded.
In the interest of time, you'll be okay if we share these slides. I think we'll quickly have work around, or maybe you want to quickly cover in next 30 seconds.
Yes.
Yeah.
Uploaded in the dashboard. And we also have a home isolation team which looks into the same matter. Next. So basically, with increasing COVID cases and more than 80% of people under home isolation, integrated digital technology will be the most time and resource efficient method to manage the huge caseload. We have successfully implemented this and we have integrated Step 1 digital platform to provide counseling, and we use IVRS calls to follow up and visit the patients at home. Next. And this in short is the way it works, as I already discussed. So basically, COVID has definitely enabled digital transformation. And in NDHM, we are doing all the best we can towards reaching out to people and ensuring integration is done. But at the end of the day, some important questions remain in NDHM which need to be answered. On the one side, we have a digitally enabled IT technology which tells us the way how we can integrate data. On the other side, we have one platform in NDHM, what is called integrating the data of the individual's patient details in this health ID. What are the data which can be shared in the health ID? Because he can open and see his data. For example, a person has cancer. Sometimes a disease which is endangering one's life, we cannot straight open up to the patient. We usually have a patient's relative with whom we can talk with. So how much of data can be really shared in the individual health ID is one question which needs to be answered. Whether we have technical people on one side, we always felt along with JIPMA that there should be eminent panel of doctors from AIMS, JIPMA and BGMR who should sit together and see what are the data of individual which can be shared in the health ID platform, which he can see or which he should not see. What are the things permitted? So data privacy issues definitely remain in NDHM. And some other difficulties we have with regard to digital technology is digital security and privacy of data. These things need to be looked into. But definitely, Digitization has given us more opportunities in easing daily working, and it definitely helps us in projections and planning. For example, once we get data on a particular database, whether it is about COVID or about vaccination, it helps us plan the next day very well. Thank you.
Thank you, sir. I think one thing which is very, and I think Raj, it's building up for you only. And I think some of the panelists which just spoke before this and this presentation also, you can clearly see there is challenge in terms of while technology is there, I think the reach is a problem and how do we take it to the last mile. So in today's pandemic scenario, I can say that healthcare sector needs a realignment, if not refactoring or something else. But as a service provider, would you like to share how can you contribute, maybe uplift, streamline a lot of the projects which are happening? Over to you, Raj.
Sure, Prashant. We are already over time, so I'm going to take a few cues from what
we started late. You have some time, so it's
so I'll take a cue from what I heard earlier, right? So there were several examples given in terms of Anmol, e-Sanjeevani, what we're doing from an RT-PCR perspective, and so on and so forth. Now, if you think about it, it's never about the technology stack first, right? It's always about people first. You and me as the citizens, what do we want? How do we want it, right? Do you really want to go to 5 different portals if you have a problem? Do you want to call 10 different numbers? Or do you really want to call? Do you want to do a WhatsApp chat, right? So in today's time, if I look at myself as a citizen, what I want is maybe one portal where I can go. I do not want to enter 5 different things out there. I may be in a position where I don't want to call. I want to chat with somebody, right? Or maybe I want to do a video call at that point of time. So in e-Sanjeevani you can do it, but not for everything. So the point is that as a citizen, what I want is an integrated service. Is that integrated service available today? The answer is no, right? So that's the main point, which I believe, and it's not about us as a service provider per se. It's about what I as a citizen want, and can we, everybody whoever there is there in the call, can we come together and bring something which fundamentally helps us, which is the citizens of India, right? And of course, in the whole thing, it's also important that how do we make it secure? So if I now flip the question and get to what you're asking in terms of tech stack per se, fundamentally it should be cloud first, internet first, and with the security across kind of a design, where I should be able to access it from anywhere, whether it is from at home or from while I'm on the road or whatever, right? So that's how we look at it. And as a service provider, then how do we ensure that we kind of help that implementation at the scale of India, which is unprecedented? That's what we need to look at. So back to you, Prashant.
Sure. So Raj, I think you covered from in terms of how you can contribute and help, but I think I'll bring one common point. And while we spoke about healthcare, we talked about applications, we talked about services which has to reach citizens. But I think security is one area which maybe Raj, we can first take your views in terms of data security. Privacy will always remain a concern here when it comes to healthcare. While we are in COVID times, nobody is looking at it. But how do we solve this problem? So your views, and maybe then I'll open it to
Sure. Yeah. So, of course, security is important everywhere, but specifically when it comes to health, it's extremely important. Now, if you think about today's time, for the people who are there on the call, who are using a smartwatch, for you, your private security is not a concern of yours, because if you have a smartwatch, your entire health data is going to the cloud, and you've just allowed it, right? And they can know what you're going through at this point of time. Now, what's happening is the PDP bill is coming in, right? And there's brilliant work which has been put on that, and we would certainly see that there'll be guidelines around it, and which will be applicable to not only the industry as a whole, but specifically to this the medical sector, the healthcare sector. This will have a larger implication, because today, if you look at, we did a work on, how does the architecture look like, right? Who are the actors who come in? So, for example, if somebody wants your data, then who can gather your data? And so from the insurers to the hospitals to somebody who's clearing your bill, everybody will get to know that what you've gone through, what your relative has gone through, what's your ailment, and then they can misuse it or use it or whatever, right? So that's what the entire bill kind of tries to address, in terms of how do you ensure that who gives the authorization of that data and who is the data custodian per se, right? And how do you then ensure that your PII, which is your personal identification number, and with your PHI, which is your personal health information, they're kind of, your crown jewels, right? How do you save them? How do you ensure that they are not freely floating around for people to use? And that's where a concept of POC, or Privacy Operations Center, is what we are building. And going forward, this is something that you'd see as a method, as a service. I think Yasin, you've raised your hand. Do you have a question?
I think I'm sure someone wants to add something.
No, it's not a question. I actually wanted to just add on to something, and it looks like it's winding up. See, this is a very unique panel. Like, so many of us working in the health departments of various states and UTs coming together and discussing what we have been doing on the digital front. So there's this thing that I would want to bring out, something from my end. There's a lot of development going on. A lot of applications, a lot of IT tools. Most of them are brought down. They are forced down by the center. I won't use the term forced down because they are actually our starting point for a state like, or a UT like J&K, which is not that much IT evolved. Frankly, we depend on the ministry a lot for whatever they roll out. They're just like off the shelf for us, and we likely implement it. And then, we have been like doing a lot of development at our own end, coming up with tools specifically for COVID control and otherwise also. And I'm pretty sure all my colleagues here in other states are also doing the same. But I'm bringing this up because we have, people from Tata and VMware with us as well. And we've spoken about NDHM. This view about where all it is leading in the coming decade, especially with the aim and objective of NDHM in mind. I see a lot of efforts going wasted, because a lot of this, hard work is transient. It's only going to be, those apps are only going to be used for a particular period of time, or for a, smaller regional area only, and wouldn't have that level of scalability, that possibility of scalability, because they were not designed as such. So, and we had, a senior from NIC over here as well, and Dr. Sood from CDAC as well. A suggestion that I want to pitch forth to my fellow panelists here is that we certainly need standardization of whatever IT development that happens, either at the ministry level, at the central level, or at the state level, so that there can be seamless integration and compatibility in everything we do, so that if whatever we come up with has some, future sustainability, it fits into the system somewhere, and it is just not, a run-of-the-mill addition, a patchwork addition to somewhere in the system, which will possibly be deemed redundant or become a vestigial organ of sorts in the coming future. Because that is something I've experienced myself. We bureaucrats have, in the process of innovating, have forcibly developed apps for almost everything, and in some areas, I think there's this, app culture is actually leading to over digitization and kind of, making things more complicated when we could do things the simpler way. However, long story short, my point here is that NDHM, in NDHM, we have the NDHB, the National Digital Health Blueprint. And I'm sure that there are teams within NHA which are, working on it. If those standards could be made public in the sense, and they could be accessible to all the developers, IT developers everywhere. And these sort of conversations, there should be an ecosystem where all the IT developers and bureaucrats like us and other officials working in this sector can regularly talk about it, so that the progress and development happens in a streamlined manner. That's all. Thank you.
Sure. Thanks. Final words from anyone, and I think before we sum it up. So if somebody wants to add. So I think we had a very good and detailed discussion. So, okay, looks like thank you everyone. I think it was a great discussion, and it was not just, I think we got perspective from NHA, we got a perspective from the Ministry of Health, then various states, how they are implementing it. And then Dr. Ramesh, obviously, I think ran through the entire workflow and how it's being done over there. So obviously, I think it's clearly spelling out technology is an enabler here. While there is a need for adoption of standardization, more security around it, cloud is a key in perspective to entire digitization across healthcare, as well as maybe modern applications also need to come in where the faster rollout integration can happen. So, Mr. Adhikari, over to you.
Thank you so much. Thank you so much, Prashant. And thank you so much to all the respected panelists for joining us today on discussing this important topic about transforming and digitizing health infrastructure in the times of a pandemic. And thank you so much, Prashant, for also, moderating such an august panel. It's not always easy to have, such a stellar panel, and then try and manage with the time and try to get all the thoughts possible from all the respected panelists. Thank you so much, everyone. Thank you, and thank you, Prashant. Over to you, Prashant.
Thank you. Thanks, Nodal.
Thank you. Thanks, everyone.
Thank you, everyone.
Thank you.
Hello.
Yes. Yeah, Pragya.
Thank you, everyone. Thank you for joining us. I just wanted to say that we will compile these deliberations in report and we'll share with all the stakeholders. Thank you.
Thank you.
Thank you so much. Thank you. Thank you.
Thank you.
Thank you, audience.
Thanks,
Thank you so much. Thank you for joining us.
Thanks, everyone. Thank you.
Pragya, do we have that? वो आप नहीं है ना? ठीक है, डन आप ठीक है, ओके। मेरे को अब कुछ नहीं करना ना, बस ठीक है, डन थैंक्स, बाय।
Pragya, can we end the webinar?
No.
Now, I think we can.
No. Yes, Ragni, we can end now.